This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is our Advocacy in Action feature, making our 15th appearance at ASCO and one of our very best.
I would say, as a social worker and the CEO of Cancer Care, one of the things we always say in social work schools, start where the client is. And one of the big issues is that a lot of the calls coming into us are from the client that doesn't really know anything about palliative care. They don't know to ask that. They don't know, even what you're talking about. The term can be overwhelming in itself. And yes, cardiology has become more of a household name. People know what a cardiologist does. But I think one of the things that we see a lot at Cancer Care is because of the telephone and the internet, people have access to us from rural areas as well. So I actually just had a call before this of a friend whose father died, who had 3 years, and he did have palliative care, but only because his children lived in urban areas that knew more about it. He did not. And I think one of the things we have the ability to do is to reach the person in the urban and the rural area where there's one doctor. There isn't a team. And I think one of the things we do a lot at ASCO and major medical center meetings in major cities is talk about everyone having this access. The person that doesn't know to ask that term, the person that doesn't have access to a team but has a community doctor, are a lot of the people that are affected by cancer. Do you want to address, I'm wondering if you could address how we can, as groups, move that forward in getting them the access to that information?
So I think it could begin with us telling patients about what they have the right to ask for, even without the label. That every patient should have access to information about what to expect from the therapy, what's a reasonable cost in terms of side effects, probably cost in general, but cost in terms of side effects. What are expectations for what's going to happen over the next year? How they access support emotionally, but also for symptoms, for them, for their family. That should all be something patients know they have a right to from the beginning and across the illness. So if we teach them to ask for it, whatever we call it, it doesn't matter.
I got a call recently from a couple, and this is a gentleman was dealing with advanced esophageal cancer, fairly young couple, and his disease advanced very rapidly, and they had to declare bankruptcy. And when I started working with them and met them, he had a private discussion with me saying, I have no more quality of life, but she's not ready. My wife, she's not ready, and I'm going to try another trial. I have to do this for her. And I could tell at that point he was having trouble breathing, and it was very painful. And they'd never even heard of palliative care. Finally, I said, have you talked to your doctor? So his community oncologist gave him some pain medication, got him on some oxygen. And then he decided to go try to find another doctor and was sort of in between systems. And they called and said, the bill for the oxygen came, it's $200 a month, and we really can't afford it. I'm going to stop the oxygen. I said, no. One, you need to talk to a social worker, and you need to get a referral to a palliative care specialist. You need help, because at some point you'll need hospice. And so I went and I Googled in my area, palliative care specialists. So I found a couple of hospice organizations, but I was struck by how difficult it was to find, and I know it's a clinical specialty. Finally, through UCLA, I was able to get them to a program. I worry about how do people know. And Linda and I were talking about this because I assumed that every cancer center would have a palliative care department. I learned that that's not so from Linda. So it's even worse in the community because it's even more fragmented. So I want to ask you, how do we bridge that gap? And how do we also make it okay for a patient to say to their medical oncologist, thank you, I'd like a little bit more, because I didn't know until I had my first palliative care consult, I didn't know what it would be like. I never had such an intimate discussion like that with my medical oncologist. They don't have time for that. And for a medical oncologist to take on the issues, first of all, a doctor has to be really comfortable within their own skin. They have to have a chance to think about the very personal issues in order to address them with another human being.
So this issue of the availability and accessibility of palliative care, I think will get better with time, because now that it's a certified medical subspecialty, it's got to become part of every medical center. I mean, you're not going to be able to sell yourself as a major medical center without it. But it's going to take time, and there's a bigger workforce issue in palliative care than there is in oncology. And that's why I think we need to push both. But hospice is one way in, but it's scarier, and it's only appropriate near the end of life. There is the myth out there that hospice requires that you give up therapy. Legally, that's not true. That legally, Medicare does not require that you give up therapy. The problem is that hospices can't afford it, and they have to take on all of the costs of care. But that leads to the discussion about what's the balance here. The bigger hospice programs, some of them will do it. Most of them cannot, but it at least opens the door to the discussion. There isn't an easy answer. If we have these accountable care groups and organizations that integrate it, we'll have multi-professionals that provide it. But that's still a ways away, I'm afraid. So I think one of the problems is too many social workers these days get trapped dealing with transportation or forms, and they don't get to use their skills, and the patients lose that benefit. And so we need to make those kind of things work better too.
I agree, and if I could add to that, social work positions have been taken away, been realigned for transportation,
Yes.
case management, not the psychosocial component, which is one of the things that makes cancer care so different, is that it is social workers dealing with the psychosocial aspects of cancer. Social work as a profession has been slimmed down and redirected, and so that is why those conversations, and I say coming into us, where a social worker is making an assessment, even if it's a financial need, we know behind that is what is behind the financial need. It's they can't afford the care for the palliative care or for the whatever the issue may be. That's where the psychosocial understanding of it has to come in, and I couldn't agree with you more. I also think that's one of the reasons why we know in the more rural areas it's an issue, because we do get those calls and we do get to make those assessments, and I think it is heightening awareness as a group, and social workers are an important part of the palliative care team.
This fear of palliative care and not knowing about it isn't just rural, unfortunately. I saw a new patient with breast cancer last week, and she came in, she said, I was a little afraid to come see you because I saw you also do palliative care.
Right.
And so we talked about why that was a good thing, not a bad thing, but she was terrified, actually.
Yeah. I have a question, Dr. Van Roon. So if two kinds of patients, the one on Medicare, one, say, with a private health plan, if they wanted to access a palliative care, a care doctor, are they going to have to first, say, for the private health care person, do they have to see if their policy covers that? Or if because, as you say, they're now certified, a recognized subspecialty, is that not an issue?
It shouldn't be an issue. It shouldn't be an issue any different than whether or not you see a cardiologist.
Great.
Right.
It
But
should
it's
be
a question you should ask.
Yeah, it's
Because there may
related
not
to
be
your
coverage.
insurance.
Right,
yeah,
right,
but it's not different because
So
it's
you may not
palliative
have
care.
coverage, though.
You may not, because you don't have coverage for any referrals
Okay.
to
Right.
secondary physicians.
And Ray, something interesting, yesterday one of our interviews, I think the palliative care specialist mentioned that, I think it was Aetna, I don't remember what company it is, but that they review patients' charts to see where they are in their life
journey?
cycle of treatment. And based on their advancing disease, they may get a call from their insurance company from the offering support to help them seek out palliative and hospice care, because in the end it lowers their cost.
So I think those are the wrong reasons and it's the wrong message. I think when we talk about palliative care as a way to prevent futile care at the end of life that's expensive, we're selling everything about palliative care short.
Right.
It should really be about, and it is about, giving patients what they want, not taking things away because they're afraid. So we need to deal with the fear. We need to talk about what's the real outcome if you take this therapy versus you don't, and what can we offer you instead of that therapy, or with that therapy if you choose to take it. But it should never be about, we want to save money for society. And if we really give people what they want, we actually will save money. But that should not be what motivates this. Thank you.
Dr. Jamie Van Roen. Thank you so much. Shirley Woods, Linda House, Helen Miller from Cancer Care. Thank you all.